All right. Thank you guys so much for watching this go-to meeting called Documentation and Billing for Critical Care. We're doing this for an IPA in Macon, Georgia, Optum Health, and we like to share it with everybody. But when we put this presentation together at the beginning of the year, we really had no idea that this is going to be filmed during the height of the COVID-19 crisis and that ICUs would be full across the country. So it's really kind of a timely talk. And I'm going to go over critical care with you, some rules and regulations. I don't know if it's my most fun talk to do, but it is a timely talk, and it's a talk that can result oftentimes in physicians having payments recouped because of the misunderstanding between the definition of critical care based on the CPT book and based on the definition of critical care in the CMS carrier manual. So let's go ahead and start. If you ever have any questions, you can always hit me up on thecodingeducator.com. That's my website. Lots of good free stuff out there. You can email me there if you get lost and can't remember my email address. Just in the subject line, make sure that you let me know you're one of Linda's folks so I can return your question, just in case you have to go. Okay, so what we're going to do today is I'm going to talk to you about clinical conditions that are best associated with critical care. We're going to find out exactly what to document to avoid any compliance issues that people might have. We're going to talk about, just make sure everybody's muted. I've got everybody muted on my end here. So Linda, if you're still on the line, I'm still kind of getting some feedback from your phone. We're going to review the time requirements for various levels of critical care. We're going to see how to count time, discussing issues with the family. And we're going to look at some services that are bundled and unbundled with critical care. So, if you're a certified professional coder at some point in time, when you took your CPC exam, there's usually one or two questions about critical care. And so we're going to talk about those today. And if you're a doctor who bills for critical care or a coder who bills for critical care, it's important. I'm going to give you some really good screen caps of things to document. So the definition in the CPT manual, we'll look it up if we're extremely bored, is that one or more vital organ systems is impaired such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. And that's oftentimes why we see that a patient's in the ICU, and it also says that it requires high complexity decision making to assess, manipulate, and support vital organ systems failures. This is the definition that we see in the CPT manual. It's pretty vague, and it would lead you to believe that if somebody was in the ICU in respiratory failure, that if you were rounding on that patient, you could bill for critical care, and that's what most doctors think. It goes on to tell us that time spent engaged in work directly related to the patient care, whether it's spent at bedside or elsewhere, is counted. And these criteria assumes that you're taking an ongoing and active role in managing the patient. So according to the CPT, which is written by the American Medical Association and not by CMS, even though CMS endorses it, requires that there has to be evidence in the note, present in the medical record, an attestation that critical care was provided. So it's pretty cut and dry, and that's why you have CMS coming back in their manual saying, well, that's all nice and dandy, but we have another definition that we would like to use. And when we look at that definition, you're going to see that we need some additional audit tools to make sure that we're using this appropriately. Now, CPT gives us some examples of vital organ system failure, CNS failure, circulatory failure, shock, kidney failure, respiratory failure, metabolic failures. But the key thing to remember is sometimes patients are in the ICU being monitored, but I don't want to say that they're stable, but this is kind of where the difficult part of looking at critical care notes comes into play when you look at CMS and CPT guidelines. Because again, just because somebody is in respiratory failure in the ICU doesn't necessarily mean that they would support the use of critical care codes. And since most insurance companies default to Medicare's guidelines, that's why on post-payment review, a lot of patients who fall within this category are denied if you bill too many critical care services. If people are on thrombolytics, antiarrhythmics, epinephrine, atropine, people are having fibrillation or aflutter, they're on Narcan, nitroglycerin, GLP. You know, the nice thing about this list is if you're an auditor and you're looking at 99223s or 99236 or a 99220, and you're always trying to figure out what are some great examples of high medical decision making. You know, CMS has the definition of medications that require intense monitoring for toxicity, parenteral controlled substances. This is just kind of a nice list. If they're not in critical care, but they were seen in the emergency room or by a hospitalist, and you're ever running across a patient who has one of these problems, this is also another really good way to know how to assign high level of complexity. So you're going to find out in just a little bit that a patient might be in the ICU with chronic kidney failure, and they don't necessarily meet the criteria for critical care because the doctor didn't spend enough time with them, or it didn't require his or her intense intervention at that time. That's when you can usually default to one of these subsequent hospital care codes or an initial hospital care code. But you can't bill both, with one exception, and I'm going to talk about that. Now, the CMS definition of critical care is a little bit different. We're going to see here that I've put in bold that while they'll use the same information that was available to you in a CPT book, they talk about the fact that before you can bill critical care, your doctor has to show that their urgent basis, if they fail to initiate interventions on an urgent basis, it would likely result in sudden clinical, significant, or life-threatening deterioration in the patient's condition. So we see that CMS goes beyond the CPT description of critical care, talking about how the critical care that you're going to bill is requiring the doctor to act urgently at that particular point in time, which doesn't mean that you just get a pass because the person is in respiratory failure or in renal failure or central nervous system failure. Your doctor has to be doing something right now in order to stop that patient's further declining, and that's the big difference. And I'm going to show you how to document that in just a little bit. So CMS goes beyond the CPT description by adding critical care services must be reasonable and necessary. Delivering critical care in a moment of crisis or upon being called to the patient's bedside emergently is not the only requirement for providing critical care. Treatment or management of a patient's condition in the threat of imminent deterioration, while not necessarily emergent, is required. So that threat of imminent deterioration is really important. So unlike CPT, CMS not only requires the illnesses that we went over, but they have an added inclusion of high-level treatments and interventions to satisfy the critical care criteria. So too many times I work with hospitalist groups or physician groups who go to the hospital who are getting denials on post-payment review for their 99291 simply because they don't have a sentence or a paragraph that summarizes this information appropriately. So even my own billing company 5 or 6 years ago said, you know, we're getting a lot of denials on post-payment review. Do you have an audit sheet that we can use? Well, the handout that Linda would have sent you looks like this. So if you're watching this on Facebook or YouTube, you don't have this, but you can screen cap it. I just took all of Medicare's requirements and I put them on a simple audit sheet. Now, what I do with this audit sheet is I use it to audit critical care notes, but I also use it as an educational tool. You know, doctors aren't doctors because they fail. You know, they want to know what to do right. They want to play the game appropriately. So what this little handout does is it gives you a partial list of some complicated medical condition that supports 99291 and 99292, but it also highlights CMS's guidelines. So on the left, you have some conditions. On the right, you have the definitions that a doctor can read. And then down here, we're going to see this later on. CMS has the two criteria. It has the clinical condition, but it also has the treatment criteria. So you have to meet both of these criteria in order to bill critical care. Then you also have to make sure that you take a look here where it says the high probability of sudden clinically significant deterioration in the patient's condition requires the highest level of my preparation to intervene urgently. I provided critical care services requiring my... Now, you may think this is ridiculous, but I think it's ridiculous for a 99222 that we have to document 10 review of systems, that you have to document medical, family, and social, and you can't say non-contributory. I am auditing records this week for a hospital up north, and I'm down, it's the first time I've audited them, and I'm downcoding their records because they're not saying their review of systems correctly. They're saying 12-point system review was negative, and their Medicare carrier requires you to list 1 or 2 pertinent positives and then say all of the systems reviewed were negative, and they don't accept 12-point system review. They're doing neck, extremities, head, and counting those towards their comprehensive exam, and that doesn't make sense. So when I explain to doctors, it literally is just a game. So if you can learn how to document, you're really good to go. Then I have a little cheat sheet here that I go through to make sure that they're documenting things correctly. And everything works out fine. So I go over this kind of stuff, and then in just a little bit, I will show you a simple statement that you can use with your physicians to ensure that on post-payment review, if you're ever audited, you've done exactly what they want. Just like if you are doing an abdominal exam, I change that to gastrointestinal just to play the game. Medicare has a similar type of format that they go through, and if you say the right words and can support them, if you ever get called out on it, you're ready to go. So CMS gave us some examples of the type of patients who are in critical care typically, and these are urgent things. Here's a patient with she had a AAA resection, and now she's coming in, she's on a ventilator, post-mitral valve repair, hypotensive hypoxia requiring respiratory and circulatory support. These are examples of things that you'd see on the left-hand side of the audit sheet. Again, hypoxic, hypotensive, tachycardia, just to kind of show you. And again, a good thing to do is this presentation is not going to be but about 30, 45 minutes. Now, when it comes to time, there's a option in your CPT book, even though critical care reads first hour, in the front of your CPT book under the heading of time, we'll find out that there are certain codes where you only have to go a minute past, you only have to go 1 minute past the midpoint. And critical care is one of those codes. Hydration, infusions. Physical therapy codes read 15 minutes, but half of 15 minutes, if we go 1 minute past the midpoint, that's 8 minutes, and that's why those are called the 8-minute rule. If we look at E&M codes, 99233 is a 35-minute unit floor code. We can bill that if more than 50% of our time is face-to-face unit floor time in counseling or coordinating care. So you still have to do on an E&M, you still have to do the whole unit floor time was 35 minutes, but you only have to document that greater than 50% of that time was spent on the unit in counseling or coordinating care and what you were doing. Now, I want you to remember 99233 because there's going to be times when your doctor might go to the ICU to see a patient and they don't spend the required amount of time, minimum amount of time of 30 minutes. So when it says less than 30 minutes, that's when I like to go with the 99233. Because if you document that, you're not going to be having the ability to do a 35-minute visit, because that would be more than the 30 to 74 minutes that you need for this level of service. But there are times when you have a patient in the ICU who has medical conditions that are high complexity, and they have several of them. So you might be able to get the 99233 out of the 2 of 3 requirements that you might be familiar with. Or you might spend 35 to 40 minutes on a patient. Your urgent time, you're not urgently intervening in the patient's problem. They don't meet the criteria to bill critical care. You've spent 35 minutes, your doctor doesn't know what to do. So in that case, you might bill your 99233 on time. So you can get it if they're not requiring your urgent intervention. You might be able to get the 99233 based solely on, history, exam, decision making, 2 of those 3 components, or on your unit floor time just because they're in the ICU. And this is normally what I tell doctors to do who are simply rounding on a patient who's in the ICU. So a lot of times doctors can only go to the ICU when they're rounding, and they're not called to the ICU. They're not urgently required to be in the ICU. And that's when we look at the 99233. I also tell doctors another great tip is if you are rounding on a patient in the ICU, to make sure that you say that, the chief complaint or the HPI. Remember, the auditor may not know that bed number that you're putting in your notes is an ICU bed number. So I always like to have doctors write down, chief complaint, Mary Jones in the ICU following up, STEMI or non-STEMI or stroke or hypoxia or hypotension. Let us know up front where they are. Now, the total duration of critical service time is based on the time spent evaluating, managing, and providing the critical care services to the patient. But a lot of times doctors think that it only is the time that you're at bedside with the patient. Now, time spent documenting activities included in the critical care time does not need to be continuous. That means it can be non-continuous. So it may be aggregated. So you may round in the morning. You may have to do critical care in the morning. Then you get called back to the ICU later in the afternoon. Those times can be added together, okay? Those times can be added together. The critical care clock stops, though, whenever separately reported procedures are performed. So if for some reason a patient is coding in the ICU, you can't count the amount of time when you're billing for your CPR. So if you're running a code, that's 92950. So that time that you're running the code has to be exclusive of your critical care time. Okay, so if you're on the floor for 45 minutes and 20 minutes of that time is doing and coding the patient, then you have to back that 20 minutes out of the 45 minutes, which would only give you 25 minutes of critical care time. And in that case, you might do the 99233 with a modifier 25 and your CPR, which is 92950. Or if you had to intubate a patient, that time isn't counted towards your total critical care time. And you have to look at, whenever you're auditing records, if you see a 99291 billed with a modifier 25 in a procedure, you have to make sure that your doctor has included the fact that the procedure time is not inclusive in your critical care time. So now let's remember the criteria for documenting critical care. We have to make sure that our doctors have the clinical condition, which is part of CPT, but the treatment criteria. And that's the urgent basis kind of statement. So if you have a phone, an iPhone, and you want to take a picture, this is a statement that was developed by the Intensivist Society years ago that captures all the requirements from the AMA, from CMS, in one nice little tight sentence. This is a blank white male with blank. For the record, I spent 60 minutes in constant attention with this critically ill injured patient. The high probability of sudden clinically significant deterioration in the patient condition required the highest level of my preparedness to intervene urgently. I provided critical care services requiring my direct and personal management as noted below. So in this one paragraph, you've addressed the clinical criteria, the treatment criteria, the time. You've identified the medical condition that the patient has. And on post-payment review, this one sentence meets all of CMS's requirements. Now, I would put this at the top of my note because there are no requirements for review of systems, physical exam, data points. None of that's required for critical care. What the auditor is looking for is this kind of statement. Now, I tell doctors not to fake it. If you don't feel like you could stand up in front of the medical director and your record doesn't support that paragraph, then don't bill critical care. This isn't a paragraph that you can use just to go over to the ICU and bill critical care all day. You have to mean what you're writing down. And a lot of times doctors will say, well, you know, I knew about the CPT definition, but I didn't have to intervene urgently with this patient. So this, again, kind of helps you when you're walking that thin line between, is this a 99291 or is this a 99233? Now, critical care time also may be spent discussing the patient's case with staff or discussing with family members. Oftentimes patients are not capable of making their own decisions. So when we're looking at our time statement here, time spent discussing the patient's case with the staff or family can count. The one that's the most confusing is with family time. If the patient is unable or incompetent to participate, and a discussion is necessary for treatment decisions, then we can count that time that we have a family member discussion. You have to just document the medical necessity that the patient is unable or incompetent to participate, the necessity to have the discussion, no other sources were available to obtain a history, or because the patient was deteriorating, I needed to immediately discuss treatment options with the family, and a summary in the medical record that supports this medical necessity. Now, where I see this as a problem is doctors will oftentimes not use, I'm going to scroll back, if you're not using my paragraph, you cause a lot of confusion on post-payment review when you start talking about family discussions, because a lot of times these family discussions happen outside the lobby. If you're unfortunate enough to have had a family member in the ICU, you know that oftentimes you're sitting up there in the ICU waiting room for hours at a time, eating hospital food, Subway, and you just wait for a doctor to come out to tell you about your loved one. Well, those conversations that aren't medically necessary, just updates, aren't included in your critical care time. But a doctor sometimes will write, family discussion is included in my critical care time, but not necessarily discussing why they're counting that time. Was that time because of one of these four reasons, or was it because you were just updating the patient? Because anything that you do that's not at bedside with the family doesn't count unless it's dealing with the patient's critical care services. And you have to make sure that you document these things within the medical record to support family time. Telephone calls to family members or surrogates may be counted towards critical time only if they meet the criteria described above. You know, there's a lot of instances where, again, no one's available to give history to. So if a doctor was on the phone with the family member, because I'm talking to you guys in Macon, and if I'm in Augusta and the doctor calls me to get a medical family social history because of a traffic accident, that time counts as long as the doctor outlines that amount of time was spent on those issues. Another issue that we don't really run into that often is what's billable with and without critical care. Now, you guys know a few years ago, a single view and double view chest x-ray code changed, 71010 and 71020 changed to 71045 and 71046. But if you open up your CPT book to the critical care section in the front, you'll see this little coding tip in here. And this coding tip gives you a list of all the things that are bundled and can't be billed separately into critical care. All right. But the problem is a lot of times doctors think just because they put a patient into the ICU, they can't bill anything else during their visit. But there are some services that are not bundled and frequently missed on post-payment review that you could have billed for. And I wanted to just give you a list of those. Now, if you take my coding class, you already have these lists written down. But you can do CPR in the ICU. You can intubate somebody. You can put in a non-tunneled central line, fistulas, thoracostomy, and run an EKG, interpretation and report only. A lot of those things, other than the EKG, depending on your carrier, would just require the 25 modifier on the ICU code. But again, if you put a 25 on an ICU code, you'll remember what I cautioned you about. The note has to indicate that the critical care time was not inclusive of the procedure code time. So if you want to snap a photograph of that. Now, CMS gave us some examples of the type of patients, the clinical criteria that a patient would have. And then I wanted to go into Appendix C to give you the type of examples that CPT gives you. So here's a patient in cardiac arrest, 40 minutes of critical care services, transferred to the cardiac critical care unit. In this instance, the physician, the ED guy, did 40 minutes of critical care and reports 99291. Because you can't bill, there's only one time when you can bill an E&M code with critical care, and I'm going to explain that to you. So in this case, the patient got a critical care from the ED, and he got a critical care from the cardiologist. Okay. Two pulmonary specialists who share a group practice each provide critical care services at different times. Now, that's the key, at different times. One of the rules that you're going to see in just a little bit is two doctors cannot do critical care at the same time. So the caveat to my statement is doctors always say, well, do I have to do a start and stop time? And I say not required to, but it's not a bad idea. Because if an insurance company gets two critical care claims on the same day, they usually only pay the one that was reported first, and then you have to go and prove that your critical care time was different than somebody else's. He's been in the intensive care unit for 4 days following an MVA. Both physicians may report medically necessary critical care services provided at different times. One doctor would do the 291 for the initial, and the other one would not get a separate 99291, but they'd bill their time together. So in the first example, they're two separate doctors, two different specialties, two different groups. They both get to start off with the 99291. If you have the same group practice rounding on a patient who has urgent requirements, now remember these are Appendix C requirements, which come out of the CPT book, which might not necessarily meet the CMS requirements, but they don't know that when they're writing these. So if that second doctor doesn't require urgent intervention, he's just literally rounding the second pulmonologist on the patient. The question might be then, well, does he get to add his extra time to be able to pick up that 99292? And the answer would be no. So I need to tell you how the second pulmonologist would bill if he doesn't meet the treatment criterion for his second visit. But let's just say, for example, he does use my paragraph and it is legit. You'd add together the time for both providers and bill your 99291 and 99292 accordingly. Here's a 79-year-old who comes into the ED. The emergency doctor calls his PCP. Primary care visits the ER and admits the patient to observation for monitoring. He goes into a cardiac arrest. The primary care provider who's over there is at 50 minutes of ICU time. On same calendar day, the condition deteriorates and it requires an intermittent critical care services. In this scenario, the ED should also report the ED visit, and the primary should report both an initial hospital and a critical care service. Now, I just wanted to kind of go over this with you because in this particular case, just to go slow from a coding nerd standpoint, patient comes into the ER and the PCP also sees him. So the ED guy simply gets to bill his emergency room visit, his 99284, 99285. But the PCP admits this guy. So the PCP admits him probably puts him in observation. Maybe he initially puts him in as a 99220 or a 99219. Later on, the hospital is probably going to change their status from outpatient observation to inpatient because he's meeting the inter-qual standards now. So now the doctor's going to go back, change his observation code to an initial inpatient code, 99223, but later the same day, the guy codes. So in this example, and this is one of the notes that I'm going to show you, if you bill an E&M in the morning and the patient crashes later in the day, you can bill both an E&M and critical care on the same day. But if the same physician does critical care in the morning and rounds on the patient in the afternoon, you can't bill the second visit. So the rule of thumb is you always want to document your start and stop time if you can, even though it's not required, just so we know when things happened. And then you need to remember, secondly, that if you do an E&M in the morning or later in the afternoon, if you do an E&M before critical care, you can bill both the E&M and the critical care on the same day. Hence the time requirement. I would want to make sure I went back and did an addendum in my note. But then the third rule is if you do critical care first and E&M second, you can't bill the E&M in the second E&M visit on the same day. That's kind of what this rule is showing you here. Isn't this fun? I love solving puzzles and riddles like this. Now, again, just to kind of reiterate those other rules, only one physician can bill for critical care during a single period of time, right? So if the pulmonologist and cardiologist both bill critical care on the same day, you might have to, on post-payment review, show that their times were different because you can't have two doctors doing critical care at the same time. You can't do a split shared E&M visit for critical care. In other words, the nurse practitioner can't be at the hospital running the code, doing the critical care, and the doctor just do an attestation and bill under his or her NPI number. You can't split share critical care like you can an initial or subsequent hospital or observation visit. And on the same day, critical care has to be the second code if you want to bill both services. So if you do an E&M first and critical care second, you can bill both. But if you do critical care and then an E&M, you can't bill the E&M second. Remember, too, that once that urgent treatment criteria or clinical criteria has ended, all bets are off. You cannot, I've had family members in the ICU who were watching Jerry Springer, eating a sandwich, waiting to leave. And the doctor comes over and sees them and talks to the family. There are patients who don't require urgent intervention in the ICU. Just face it, that's the fact. And I struggle with physicians trying to explain that to them because the ICU codes pay so well. So, if the patient's responding, not requiring urgent intervention, recovering, getting ready to go back on the floor, just because you're over there doesn't give you the right, from a compliance standpoint, to bill critical care services. Make sure you use that critical care auditing sheet. So we looked at some clinical conditions that are best associated with critical care, and I tell you that sheet is also really good if you're just trying to assign an ER visit, a 99223, a 99236, a 99220, anything like that. Find out what to document to avoid compliance issues. I gave you all the tools, like I always do, to try to make sure that you document appropriately what level of service you're doing. I gave you the time requirements and told you, well, you know, sometimes you might be in the ICU, you might not be critically ill, but you might want to go back to a 99233. I told you about time discussions with family, what counts, what doesn't count, and if you want to count that time, how you have to document it. And then we looked at things that were and were not bundled with critical care, and I told you that if you use a 25 modifier to make sure your doctors understand that they have to have a statement indicating that the time associated with those services was not included in the determination of the total critical care time. All right, so if you have any questions, here's my contact information. If you're a client of mine, I'd be more than happy to get back in touch with you. If you're not a client of mine, of course, I can't help you, but I'm going to stop this video now and answer some questions for my IPA associates, and I hope that you guys got a little bit out of this. Thanks again for your time. Bye.